A very good morning to everyone, and I'm privileged indeed to be, invited to speak on something which I enjoy doing, and that too, this award in the name of Dr. Lalit Verma, who has been always a big guide for me. So I just wanted to share, and I've actually cut down my talk to almost half because I see that the session is really running late. So what am I doing new in refractive surgery in 2025? While I'm doing a lot, I mean, we are all doing a lot. We are working on lenticules, and we are doing new kinds of excimer customized treatments and contour systems and ray tracing. But what's really caught on in the last year or two is a lot of people have started doing phakic lenses, and so with increasing numbers, there is also the process that you have to keep measuring the outcomes, ensuring that you're getting good results. So good success with phakic lenses depends on all these things, and I think the most important amongst these is achieving a good predictable vault, which is the last one. And I think the success of ICLs basically depends on this and how you're going to ensure that you get a good vault, which is going to give you a great outcome. So sizing is probably the most important variable when it comes to getting the right vault. And even though the ICL has been around for 25 years, we still don't have a perfect way of predicting what vault we will get with a particular ICL. And the FDA gave this clearance in 2005 for the STAR ICL. And we've been using it since then. They came up with the idea that you can add 1.1 millimeters to the horizontal white to white. So essentially what we worked with for the last 20 odd years is the white to white measurements and the anterior chamber depth, and that goes into the formula which STAR gives you. It's called the OCOS, and then that gives you a size which you can use. And white to white is basically a surrogate measurement for the sulcus where the ICL sits. So essentially we're trying to find a good correlation between white to white and what is the size of the sulcus, but in almost 10 to 20% of patients, it does not actually give you a great outcome. So you tend to get surprises. You can get high vaults and you can get low vaults. This is how the STAR formula looks, and it tends to give you a size, and it tends to give you what kind of an outcome to expect. And it hasn't changed in 20 years, so we are still working with what we started almost 20 years back. So essentially with the onset of OCTs becoming available over the 10-15 years, we started actually seeing our vaults properly. And so every patient is now followed up with the vault measurements, and not only right after surgery, but also 5, 10, 15 years after surgery. On every follow-up year or two, we tend to check the vault, which keeps going down with time. And we know that the vault keeps decreasing. And Mark Packer has come out with this and this has been changing with the Centraflow, which came in about 10 years back. Our tolerance for vault actually improved drastically, both for the low and the high vaults. So the ideal vault range has been set to be between 250 to 750 microns. And however, there's a tolerance for 90 to almost 1000 microns. So this is a very high vault, as you can see over here, almost 1.39 millimeters. And this can lead to, of course, many things, narrow angles and angle blocks and pupillary blocks and optic captures. And of course, again, if you have a very low vault, as you have over here, which is almost a flat vault, this will probably lead to ICL rotation, and toric ICLs will not tolerate that. Also cataract formation. So things have got better with the Centraflow, but they haven't got so better that you cannot, you should still not be working very hard with the vaults. And some of the new ways that you can do vault prediction and sizing is beyond the white to white. You can do sulcus measurements with the UBM, but they've not been found to be very, very inter-user. The variability is too much, so they've not been found to be great. And you can now have access to very good high-quality AIOS OCTs. Several of them are available. So we have several measurements which you can see on the right side. You can actually see the lens vault, the crystalline lens rise, the angle to angle, and many other measurements which have all been studied at length to predict what size of ICL can be used. And we are using these for the last couple of years, and this is what is new for our phakic lens practice. I'll just share a case. This patient was with a small spherical error and a very high astigmatic error, and 27 years female, was having a very thin pachy of just 450, was planned for an ICL. As you can see there, the AC depth was very good. It was 3.5 millimeters in one eye and 3.5 also in the other eye. We did the STAR calculation, and we found that this was predicting a size of 13.2 based on the measurements that we got from the calipers and from the pentacam. And we had gone ahead with this surgery using the STAR nomogram for both eyes. And we got a vault of 794 in the first eye on day 1 post-op. So we went ahead with the same size, considering that this was a good vault. Second eye got a 949. And what happened is that this was an outside outlier. Patient's vault actually increased on the post-op day 15. We had almost a 1 millimeter vault in the right eye, and again 950 or 1 mm also in the left eye. So this was a high vault. We kept watching this patient, and gradually we realized that the vault did come down over 6 months to about 800 to 900, which is fine. Now what happened is that about a year or two back, we started working with OCT-based parameters. In retrospect, we studied all our patients which had been having vault surprises, and the OCT can give, as I showed, several parameters, and you can use one of these formulas like the lasso technique, which is available free online. And there's another study done on the anterion, which gives you the Lucas formula. This is also a lasso-based formula. And they don't use white-to-white essentially for their measurements and vault prediction. Dan Reinstein has done a lot of work with the UBM, with ICLsizing.com. As you can see on the left, it does use lots of variables from the OCT or from the UBM, and this can give you a vault prediction. And so this was predicting for our patient that we should have used a 12.6 instead of the 13.2. It showed that had we used a 12.6, we would have got a 418, whereas if we had used a 13.2, it would have given us about 1,000, which is actually what happened. And this is the other formula, which was again predicting that in this patient, we should have used a 12.6. This is the lasso formula. And it also showed that if we used a 13.2, we would get a much, much higher vault. So in retrospect, we realized for many patients that this is what was happening. So what we've done is in our practice, we've switched. I won't go into the details of how we analyze this patient because it clearly shows that we should have used a 12.6, which was totally different from what STAR was predicting for us. So there have been a lot of vault prediction methods, and there's artificial intelligence formulas. One is being developed by Alan Sard and Damien Gatinel's group. We've been contributing a lot of our data to them and working out for our patients, and they've kind of come out with a new nomogram which is using deep learning. And on that, for our patients' data, we found that with using their model, we would have got almost 100% of our patients within the 250 to 750 group. And I won't go into the details because I want to finish as fast as possible. And what we are doing today in our practice, and I'll finish in 3-4 slides, we are doing vault prediction using various calculation methods available to us in addition to the manufacturer's nomogram. We also now order one size up and one size down for each ICL that we implant, and we also use intraoperative OCT. So this is how our calculation sheet looks. It uses the lasso technique, and using this, we are getting, with a 12.6, it's predicting a 652 volt for the right and the left, using a 13.2. So looking at this, we can actually choose what size of ICL we might want to order and implant for the patient. This comes from the IL Master lasso formula. It's again telling me that if I use a 12.6, I'll get a 742 volt or a 818 volt for the other eye, whereas for the 13.2, obviously I'll get a much higher volt. So using this is prepared for each patient that undergoes a phakic lens surgery. This is from a manufacturer who's also, with our help, incorporated this into their own calculation systems. They are using manual white to whites, the Pentacam white to whites, the Almaster 700 white to whites, from the LensStar and from various devices, and they predict you a vault and a size. So this is predicting a post-op vault of 410 and with a size of 11.5. Or typically what we'll do is we'll order an 11.5, a 12, and maybe an 11, which will be standby lenses for us. And this is how this is my last slide. This is how we'll do with the intraoperative OCT. This is one representative patient where we implanted the size which was predicted by all the formulas. And on IOCT, this is a 12.6 implant that we did. And on IOCT, we found that the vault was almost flat. As you can see on the right side, there was almost no vault. It's not very clear, but the vault was almost nil. So we've explanted this. We did have a standby lens with us, and we were able to explant this and immediately replace it with a different lens. Now, this might happen only in maybe 1 out of 10 or 15 patients, but when it happens, then it's a lifesaver. And we exchanged this ICL right then, but now we've made it a standard practice. In the last year, we've had to exchange intraoperatively about 2 or 3 patients where we were getting either a very high vault or a very low vault, and this has really helped us, our outcomes. And so with that, I think I'd like to close. This is this patient itself, their outcomes post-op with the vault. So I think it's been, as I said, 25 years. We're all working hard, but how can we bring it to that 97, 98% confidence level of getting good results with our ICLs? So a lot of new technology which is coming, and deep learning is helping a lot. And I think once Damien Gatinel's formula is out in the open, we'll have much, much better results as well. So thank you so much.